of the OR just to talk to you. So that's pretty impressive, right? And I bet he wants to go to bed, or do you have to go back to the hospital?
Oh, I'm okay. Yeah, I'm fine. Feel great.
Just let me get going. So you are privileged to have Dr. Hamad Farhat here with you today. He is a neurosurgeon at Advocate Christ Medical Center and Good Sam.
Yes.
And Illinois Masonic.
Yes.
He's up.
But I'm 90. But no, I mean I'm 90% here. Sometimes I go to these other hospitals. Not 90% here.
Okay. He attended Chicago Medical School and completed his neurological surgery residency at Jackson Memorial Hospital, University of Miami School of Medicine. His primary area of focus is complex spine and brain surgery. In addition to English, he speaks French, Spanish, and Arabic. So thank you for coming here and take your time.
Thank you, Susan.
Would you like some
Absolutely.
water?
Oh, that would be great. Thank you. So I'm happy you guys all came. I really am, and I'm sorry about my delay, but today we're going to talk about stroke and brain aneurysms. I don't know if any of you have had family members who have experienced some of the unfortunate experience with these two disease processes, but we're going to talk about them a little bit. And and the title of the talk, I really put it, as the state of the arts, because I want to show you some of the newest and greatest things that we can do. And the treatment today is completely different the way it was even 10 years ago. We have many more solutions, way better outcomes than we had. So we'll get started, and I'm going to try to explain exactly what we're talking about here. No disclosures here. So what we're going to focus on is really ischemic strokes, and the word ischemic is kind of important. A lot of you guys have heard of this word ischemia. It means little or not enough. So ischemic stroke is basically a type of stroke that is, simply put, happens when there's no blood flow to an area of the brain. The blood provides oxygen and nutrients to the tissue, every tissue in your body. If you don't get blood, you get the tissue dies. That's basically what a stroke is. In a heart attack, that's precisely what happens. A vessel in the heart closes off, and you can have a heart attack because that muscle basically dies because it needs a lot of energy, it needs oxygen, it needs sugar to work, things of that nature. So that's as simple as I can put it. Some people talk about strokes when it comes to hemorrhages. That's a different type, and it's more of a brain hemorrhage, like a hemorrhagic stroke that's really more from bleeding. But today's focus is really on ischemic stroke, and basically not blood flow to an area. It's not meant to be scary or anything like that, or to be complicated. It's just to really show you, this pointer, no, there's a pointer here, but does this pointer show up? Oh yeah. So put very simply, this is basically an MRA that shows you a blood vessel. So this is an artery. You can see that, it's real easy. And they have different names that you don't have to worry about. This is a hand-drawn area of this artery that comes from the neck and goes to the brain. The area of focus a lot of times can be this artery. You see my pointer right here, guys? That's a big artery that goes to the brain, and that is the most common area that can be blocked, and you can have strokes from this area. So a lot of times, one of the things what blocks the vessel, so normally blood goes up from the bottom, goes up and goes to your brain. Your brain is all the way up here. So something can fly off, like a clot, flies all the way off and gets lodged in this area where there's two branches. It's almost like a drain that is clogged, if you will. And then there's no flow to the brain, and you can experience an ischemic stroke. That's the basic concept of this, okay? And yeah, so you don't have to worry about the names. Here is what we call an angiogram. Everything black is an artery. So if you go back here, this is just an MRI. This is an angiogram. This is when we go through the groin or the wrist and shoot dye and take pictures of the blood vessel, the brain. So these are the blood vessels that go to your brain. One is what we call an AP, it's a straight view. One is a side view. So this would be a side view. This would be a frontal view. So everything black is a blood vessel. It's as simple as that. So this is a normal situation. All the vessels you can see are open. There's a lot of black everywhere. That's open. Here's a case that we have. It's a real case. This is an 80-year-old gentleman. He had atrial fibrillation. Okay. showed up with a large stroke. These numbers, the higher the number, that's 17 there, is basically a real stroke, meaning they have a lot of symptoms, and we number them. So the higher the number, the worse the symptoms are. Okay, so he wasn't moving the right side of the body, and he could not speak. And when you look at the angiogram, you see what I have circled right here. Remember this before? I mean, it's still switched because that's on the right and this on the left. But you see what my pointer is. You see there's a lot of blood vessels, and there's a cutoff right here. So there's no black. You guys can see my pointer, right? There's nothing here. See that? And this is before. And if you look at the other picture, there's nothing back here. So this is before the treatment. So what we do, we literally, the patient comes in and we do a procedure on him. And here's afterwards. This is a video that shows it. That's the same guy. Do you see all the, I'll stop it here. Oh. You see all the black here now? That wasn't there before. You see that? That wasn't there before. And this, I put in the middle the before, just for reference. So you see there's nothing up here when my point is, and now you have all this blood flow again.
What did you do to open it up?
Great question. So I went through the groin, and we use, it's almost like a drainer. I mean, I'm not like a plumber. I mean, you can call me a special plumber, if you will. We have very special devices, very sophisticated devices. Some of them are suctions, some of them grab the clot, some of them open up the artery. We have a whole closet full of those. And these are devices that have been FDA cleared. They've been through all the testing. They've been through years and years of testing. In the United States, we don't even get them first. They get even when they're approved. The FDA is actually very difficult. They're very hard to approve a device. So they're most often are approved in Europe or in South America, for example. But United States and Japan are the two hardest to get any sort of FDA approval. So when we get the devices here, though, the flip side of it, and they've been tested, they've had years of usage, so we know what's good and what's bad. So I use a special device to take the clot out. And here's the side view. You can see it. Look, again. So this is before. You see my pointer. There's nothing here. I should have changed the color of the pointer. Maybe I could still do that. So there's nothing here. And this is after the procedure.
I think you have a thing with the pointer on it.
Yeah, but it doesn't really like. But you guys see my white pointer right there, the mouse, right? So there's nothing here at all. Would you agree, right? This is nothing. And this is after. It's pretty incredible. And that took us 12 minutes when we got and I'm not saying this to brag. What the point of putting the time here, we are becoming so good at doing this, at opening up the vessel. So what do you think is hard? What's the hardest thing of this whole thing? It's getting the patient from home to the hospital. That's what takes the longest.
So time is a problem.
Absolutely. Time is brain. So,
So by the time he had a stroke, until you fixed him, was it 12 minutes or?
That's 12 minutes from he got to me on the table.
Okay.
For the treatment. Now, the faster you come, and I'm going to show you some cases here in the next few slides, the faster you come to the hospital, the better the outcome. Because what happens, and we did this in monkeys, we did this in baboons, we did it in dogs, it's very impressive, where we closed the artery experimentally, and we waited. After 10 minutes, we opened it up. Oh, the monkey's fine. Half an hour, monkey's fine. 2 hours, not perfect. You know what I mean? 3 hours, a little worse. 4 hours, even worse. So we have a curve in time. So we know that time is brain. Now, everyone's a little bit different, okay? Because what happens sometimes, you have what we call collaterals. Even though one of the vessels are closed, some other vessels have developed branches over time that can compensate for a while. But time is of the essence. There's no question about it.
Is the blockage typically a hard substance, or is it kind of soft, just an accumulation of soft material?
That is a great question. So this patient had atrial fibrillation. So in atrial fibrillation, you develop clots in the heart. because your heart's not beating correctly, and then that clot gets chewed up. That tends to be soft, okay? But sometimes you have plaques that have a lot of cholesterol and calcium that break, those tend to be hard. So it's a mixture. It's a mixture. So it's definitely a mixture. Some people have, a disease, which is actually a real disease that can cause plaques inside those arteries in the brain. Those, what I mean, those are very hard because we have to ply them open, if you will. But these are great questions.
And of course, I want to compare a stroke with a heart attack. Will the same doctor do both stroke in the brain operations versus in the chest? Or no, it's two different specialties? Because I noticed what you were described as a neurosurgeon.
That's correct. I'm a neurosurgeon who trained in endovascular. I'm dually trained, but it is a different doctor.
Neurosurgeon means you deal exclusively above the neck.
The neck and the brain, that's me.
And so if someone just has a heart attack, let's say in the aorta artery, you would not be doing it. It would be, what do you call that?
It would be an interventional cardiologist.
It's two different, okay.
That's a completely different, as a specialty is they do a medicine training, then they do cardiology, and then do the 2 years of what we call intervention. It's a similar techniques. It is a similar techniques, but they go to the heart. Now the heart is a little bit more. I'm not gonna say the brain is better because it's not what it's about, but the heart is a little bit more pliable, meaning you can survive a heart attack. You know what I mean? Because you can still move your arms and legs. But a stroke, you know what I mean? You can survive it, but you may not be able to move an arm or a leg or speak. Do you know what I mean? So that was the point of this, and you'll see. Look at beautiful, beautiful, beautiful arteries. All right, you can see what the problem is here, right? 73-year-old, you can see that there's nothing up here. That's the same. I mean, it's a little bit of more a higher view, okay? But look, I even put a circle there. There's nothing there, right? We all agree there's nothing there. There's no black there. Again, we take this patient insert. Look at that. So we did one clot. Now you see more. Now it's not perfect, and then you see a blockage right here. So now we took most of the clot out, but some of it traveled a little further down. There you go. You see there, that's still a blockage. So now the other one is open. One is open, the other one is closed. So I had to go back in. Now the second one is open, but you can see there's a little tiny blockage here too. And then I went after it, and there it is, wide open. And you asked me a question, how do you do it? Look at the tip of this. You see that clot? This is like a suction device. It's a very sophisticated small suction device that literally took that clot from way out here. Does that make sense? Do you see that here? This tip.
Where have you inserted that initially into the body?
In the body, I went through the groin, all the way to the brain.
I can't imagine.
Yeah.
That instrument there's so many left turns, right turns. Shag.
You got it. You're exactly right. It's called tortuosity. You're right. We got to do this very carefully.
Through the artery and burst it.
And you got to do it safely. You're exactly right. That is the risk. You have to do it safely. You're right on point. So there's a lot of tortuosities. So we use different guides and special wires under fluoroscopic guidance. So yes, you have to be very careful. And that's why it takes, a training to do this. You're exactly right. You got it. Because you can rupture a vessel and have a brain hemorrhage. Absolutely. That is a risk of this procedure. And the published risk of this procedure is between 7 and 8%. So there's a 7 and 8% risk of having a brain hemorrhage. Now, the brain hemorrhage, two types of brain hemorrhage. One, you alluded to, where we can perforate a vessel. The second brain hemorrhage, if the patient comes too late to the hospital, okay, when we reopen the vessel, blood comes rushing in. And if that area has already been weakened by the stroke, meaning the tissue is dead, you can have a brain hemorrhage. That's called a reperfusion hemorrhage, meaning you're reperfusing the area and it hemorrhages. So that can happen, 7 to 8%. That is a published risk. So this is an interesting case. Now, once you got this is a great case, and I hope the audio works on this. It's a 34-year-old woman. God bless her. She got 6 kids. Okay. Her oldest called 911. Now, I spoke with this lady, and she gave me permission to present this case, okay?
So can you just explain what right hemiparesis and aphasia is?
Oh, yes, I'm sorry. It says she has right hemiparesis and aphasia. She cannot move the right side of the body, and she cannot speak or, and she cannot, utter words. That's what aphasia is. And sometimes understand. So her oldest daughter was, I think was, if I believe was 14 years old, called 911. And this is with permission of the patient. No ifs, ands, or buts. You raise the right arm. Raise your right arm. Raise your right arm. Now you guys all are experts. You see the problem here, right? You see it? That vessel is closed. There's nothing up here. Would you agree? There's nothing up there. So we took her immediately. I happened to be in the hospital. She came, she came in. We took her immediately for the procedure. And look at that. You see the difference, right? Clear difference. Clear difference. And this next slide is precisely why me and I see a couple of my colleagues came here on my physician assistants that I work with. This is why we do this, because of this. This is her. This is the same lady. Isn't that incredible? So what you see in here, this is a room on the background. This is a room where we do the procedure. This is immediately after the procedure. Isn't that incredible? This is a 34-year-old woman, mother of 6 kids. Incredible story. Incredible story. And she was lucky. Her daughter called 911. She came immediately to the hospital. We were right there. I mean, she still had her shoes on. Now, I'll show you. This is another one. I mean, you guys are expert. Again, not moving the left side of the body. You see you guys are experts on this. Blocked, open, blocked, open. This gentleman right here, he's giving me a high five with a hand that he couldn't move immediately after the procedure. And he was on the phone right here. Do you see him on the phone right here? This funny story is he was at the dollar store apparently when he got the stroke, and they called 911 and brought him in. And he was making phone calls to arrange for someone to pick up his dog because he left him in the car. So, I mean, he's like with it. I mean, he's just fine. And he's like, just, get away, give me a high five, get away. I got to go rush, pick up my dog. And I was like, happy to see that. It's an incredible story. We had a 34-year-old with 6 kids. This woman, 28-year-old, 8 kids, got nothing on that 6 kids. I mean, this is 28 with 8 kids. God bless her. And that's all I kept thinking is like, do you have twins? No, just single birth. So again, she had the same problem. She was completely blocked. And you'll see here, this is before, again, with permission of the patient. Like that. Can you hear me? Move this arm right here. Can you raise this arm right here? Raise this arm. The right, no problem. Now raise this arm right here. This left arm. Can you raise it? Raise this arm. Move this arm. Okay. How about this leg? Can you move this leg? She still has the jeans on. See, she's moving the right leg. Right here. Nothing. She has her shoes. So we don't mess around. We'll go fast. Again, this is before. Completely closed. Completely closed. After. Wide open. Wide open. This is her. After the procedure. 28-year-old mother of 8 kids. Excellent. Okay, good. Now raise the left arm. Look at that. Excellent.
Did they have to do any kind of therapy afterwards?
This patient went home 2 days later. So she was normal. I mean, she was no therapies for weakness and things like that, but she wasn't weak. The other patients were not weak.
Often patients do though.
They do. Sometimes they do. Because sometimes these are I'm showing you great results to make a point. The point is, you see somebody, you guys are here. You're the first ones that are going to see the patients. You're going to be the first ones. I know it sounds crazy, but you're part of all this process. You're going to be the first ones. You're having Thanksgiving dinner. I get a lot of Thanksgiving strokes because people get together on Thanksgiving and they recognize, oh, there's something wrong with grandpa. Yeah. Somebody stresses you out. You know what I mean? It's like, there's something wrong with grandpa. Yeah, maybe you should have upset him. No, there's actually something wrong with him. It's like, he can't move. So then they end up coming to the hospital. So every Thanksgiving or Christmas, we've had some great miracles because, people recognize the strokes. Out of, so I'll give you some numbers, something to think about. There's between 700 and 900,000 strokes in the United States every year, okay? When I first started this business, we were getting 5%. 5% of those to make it to the hospital to do what we just did, 5%. Now we're up to about 14 to, anywhere between 14 and 17%.
So you're saying 5% got to the hospital in time?
You got it. That was about 20 years ago.
95% died, or what happened?
Well, they didn't make it. They suffered a stroke. So you don't always die from a stroke. You can just be paralyzed, you know what I mean? Or not be able to speak, or can't be blind, or things of that nature.
You're saying today the current number is 14%.
Between 14 and 17%.
So like 85%, there's a major
There's still
problem.
80% don't make it to the hospital in time, correct.
And just generalizing, what the magic number for the time is?
Well,
half hour at the most, or what?
3 hours. 3 hours to 4.5 hours. Now, that's very variable, depending on the patients. And we have methods, even if someone comes in late, 6 hours, 8 hours, now we can do it up to 24 hours. Okay, it is possible up to 24 hours. But obviously, the best results is the earlier. And we have methods to figure that out. We do a special scan, and I actually almost put a slide on here, but I didn't want to get too technical. There is a scan that we do that shows us how much brain is already dead that we cannot save and how much we can save. So if somebody comes in after 8 hours, 10 hours, we do that scan, or after 6 hours, we say, okay, well, this amount is dead, we can't do anything about it, but we have this much to save, so we go and do the procedure. And that is so even if they come in later. Now, if the damage is this big, and what we can save is this big, then we just don't do it, because then if we open it, we can have a brain hemorrhage, like we talked about.
Now, when these people experience this, do they have any pain?
No pain, that's the problem. That is the biggest problem. That is a major problem, because a stroke very often does not cause pain. In fact, because you can't feel anything. So it doesn't cause pain, so sometimes it's not brought to attention. And some people do have a stroke during their sleep, you know what I mean? So they wake up, not moving, can't do anything about that. Some people experience a stroke in weird places, like, and they can't get to a hospital. So it's really, that's the biggest issue. So there's a reason why a lot of people don't make it to the hospital. But, like when you see something, and the signs of stroke are obvious, it's not subtle, you know what I mean? It's like you can't, you've heard of the mnemonic. I think you went over that before I came, correct? Kate? You went over the recognition of strokes with the face, EFAST and all that. So they're not subtle. They just don't look right. They're not moving an arm. That's obvious. You can't move an arm or leg. That's a big deal, right? So those are type of things that we can recognize. And like I said, you're going to be the front guys. You're going to be the front guys. Call 911. I think they're having a stroke. They come in. And the future is going to be even better for treatment. There are specialized, I gave a talk actually a week ago, 10 days ago, talk about artificial intelligence in stroke treatments. We're going to very soon, I can give you a timeline, of course, but we'll have an ambulance coming in, fully equipped to make a very quick diagnosis. And that ambulance will be in direct contact with someone like me or the hospital, so we can even be ready. So oftentimes, and even now when you guys call us, and we do know we bypass, and we'll be able to bypass the emergency room, for example, we'll be able to go straight to do the procedure. So things are coming that are, in fact, we can even initiate the blood, there's a blood, a clot busting medication that we give, like a Drano type thing, and we give that too at the same time. So that can be administered in the future, hopefully on the scene, without even being in a hospital. You know what I mean? So these are the things that are coming up for that.
Talk once about people giving a call on 911, I think I have a problem, and they get to the hospital and there's no problem. Because I assume many people, and I include myself, was kind of a hesitancy, I have a sudden idea, Jesus, something feels different. Is it a problem or not a problem? And so the way you present it, you would say, call 911 and rush to the hospital. But there's a fear, Jesus, I'm like a fool. I get to the hospital, you're perfectly okay, just, go back home.
Sure,
So
sure.
how often, or what's the penalty, or from your point of view, come on, there's too many people coming in. And, because everybody's psyched up, call 911, and half of these people, there's no problem. So,
What a great question. What a great question. What is your name, young man?
Tom,
Tom. Well, listen, Tom, you should never, never be embarrassed. You should never be afraid. You should never hesitate to call 911. We're all adults here, and we know if there's something wrong. If you happen to be wrong, so what? And there's a lot of people actually that suffer from something called the TIA, transient ischemic attack, meaning you can have a stroke that is temporary. So if you can imagine, bluntly, you have a small clot, and then you can't move, or someone can't move, and then it dissolves. Some do, some actually go away, and then you feel better. You didn't do anything when come to the hospital. Quite the opposite. You need to get a workup so that doesn't happen again, because the next one could be a clot that doesn't go away, and then you have a real problem. You know what I mean?
What can you do, doctor, between the TIA and it going away? I mean, if we went to the hospital for a TIA, what would you do?
Well, we'll check your heart. Say, why did you have a TIA? So we're going to make sure you don't have atrial fibrillation. We need to make sure you don't have a hypercoagulable state, meaning like a clotting disorder, or a reason why you had a TIA in the first place, and you may be placed on medications like a blood thinner. We may have to have some sort of ablation of the heart. I mean, you need to work up. This is something serious. And actually, in fact, well, that's a great question, because in fact, we know from studies that TIAs are almost like a warning sign that's like a big stroke could be coming. We know that for a fact. So yes, you have to go to the hospital, but Tom, don't ever be embarrassed.
So I have a question. You have TIAs and it's a warning sign. So what do you do with that? I mean,
Yeah,
are you just very cognizant then afterward to say, okay, if something else is happening, get in right away? Or
that's a great question. So if you have a TIA, first of
what is
all,
a TI, what is that?
a TIA means you have a stroke, but it's temporary. Remember you asked me, what if you feel bad and you come to the hospital and you're fine? So, you asked me that question, Tom, right? So what I'm trying to say to you, some people can experience stroke-like symptoms. Oh my God, you know what I mean? I don't feel, I can't move my arm, and then they get better. Do you know what I mean? That's the TIA. So what I'm trying to say to you, to answer, that is what a TIA is. Okay? And this is what your question comes from. Hey, is it a bad thing? There's no penalty for coming to the hospital. There's no penalty for calling 911. That's why we all pay taxes.
But what, you're not involved with, right? A second hesitation, geez, my insurance company, then I get a bill for whatever, for all a waste of time because I'm so hypersensitive. Any comment on that, or?
I mean, I don't know about the insurance, to be honest with you. I don't know about the insurance company. All I gotta tell you, you cannot hesitate, Tom. You cannot hesitate because, there's something wrong, right? Because if you have a TIA, they'll diagnose TIA and your insurance will pay for it. Okay, that's it. I mean, they have to pay for it. You're gonna get a diagnosis when you come to the hospital. So I'm not sure you'll be penalized in any way. You don't feel good, you come to the hospital.
Well, but it might not even be a TIA.
It doesn't matter.
Something you feel and.
You have chest pain. You got chest pain. You got arm pain. That could be a heart attack. I wouldn't worry about the insurance as much, and because I can comment on the insurance. Do they charge people? I don't.
No, there's no, they may end up with a bill if the insurance doesn't cover 100%, so that could be part of.
It's a deductible though, right? It's a deductible thing, or is it?
Deductible, or like if the insurance only covers 80%, they may have to pay the other 20. So, but if you feel that the symptoms are real and you really think that it could be stroke or heart attack, you should be coming to the hospital. You shouldn't be sitting and waiting, because the longer you wait, the less chance of recovery. Okay, so that's why we encourage that T for time that we talked about. You have to call. Time is brain. Time to call 911.
Absolutely. So
brain cells are killed a minute each time you wait.
Oh, that's a great question. I think there's a number of like a million, it's, yeah, 1.9 million every minute or something like that. It's horrendous.
My grandmother had these TIAs several times. She would just fall down.
Yeah.
She'd be standing and she would fall down. We thought, well, maybe she lost her balance. She was eventually diagnosed with these TIAs. And she had them occasionally for several years, actually, before she actually had a brain bleed.
Oh, no, they
She
see
was
this?
95.
Oh, God bless her, knock on wood. So that's.
I had a patient who had 17 TIAs, and then he ended up with a very large stroke and was completely paralyzed on one side because he
She was-
wasn't
yeah.
treating the reason behind what was causing the TIA. So
Right.
for TIA, we do the exact same workup because we want to know what caused that TIA so that we can prevent that stroke from occurring.
Right.
But,
Yeah.
the more, unfortunately, the more risk you have, the more likely it's going to happen. Sure.
Well,
So, yeah, so it's important. I mean, it's important to really come to hospital and to get the reason, the underlying reason why you have the TIA.
Well, with somebody like her grandmother, she didn't realize what it was. She didn't understand what it was.
Exactly, that's what we do in this.
Yeah.
You're exactly right, 100%. That's what we do in this. I mean, that's the most important thing.
Unfortunately, I'm a person that had a symptom and blew it off because my leg became numb and not in a million years, and I think I was having a stroke. And then that was like 3 o'clock in the afternoon. But by the time I went to bed at 10 o'clock or so, I was struggling.
Oh, my goodness. Well, you look good. You're able to walk and you've recovered some?
Yeah.
Wow, that's amazing. You're a survivor.
I feel lucky right now.
Yeah, you're a survivor. You're a survivor. Congratulations. That's awesome.
So let me get this straight. When you go in, your objective is to pull back clot.
That's right.
Can't
That's,
you dissolve it? Wouldn't that be easier just to dissolve it and let it go?
well, where is it going to go? It's going to go to the smaller branches distally and close those off. You know what I mean? Sometimes it breaks off and it's actually better. I mean, you have less symptoms,
Yeah.
but it may still cause issues. You know what I mean? So ideally, we want to get it out and reopen that vessel, and that's what we try to do most of the time. These are all great questions. This is about strokes. Now, I don't know if you guys tired yet. We're going to talk about brain aneurysms real quick. You guys familiar with brain aneurysm, or what do you think, Kate? Should we? You guys want to see some brain aneurysms?
Want to hear about aneurysms?
All right. So now that you guys are experts and geographers, you know what everything looks like. So this up here is a normal vessel. It's a straight vessel. This bubble here, that's a brain aneurysm. That's an aneurysm. It's like a bubble. It's a weakness in the blood vessel. This is one type of aneurysm. This is another type of aneurysm where the whole thing is going on. The problem with these aneurysms is you can get this issue, which is a rupture of hemorrhage. So when you have blood in the brain, that's very bad. This is a very dangerous situation. When a brain aneurysm ruptures, there's about 50% chance of not even making it to the hospital. Very serious problems. These aneurysms can happen over time. Some of them are genetic, but most happen, from chronic hemodynamic stress, all the stress in the blood vessels over time with blood pressure and things of that nature. So that is the basics of what an aneurysm is. This is a case right here. A patient, basically, she was taking a bath, unfortunately, and went into a coma. And she came to the hospital and we did a brain scan. And what you see here is a CT scan, and there's brain hemorrhage. The white is brain hemorrhage. Anything white here is brain hemorrhage, not the outside. The outside white is a skull, but all the inside here, where my point out is a brain hemorrhage.
Hemorrhage means there's no.
Brain.
What does it mean?
Hemorrhage is bleeding. So this is brain bleeding. So there's brain bleeding, and the pattern of the brain bleeding is consistent with a ruptured hemorrhage. There's different types of brain bleeding. This type of brain bleed is typical of an aneurysm that ruptured. Okay? And this is an image that showed the aneurysm here. You see that bubble right there? That is the aneurysm, and it's surrounded by a hemorrhage. And we did an angiogram. This is a three-dimensional picture to really, so again, you guys are expert now. So you see all the normal blood vessels, and I'm sure they'll be able to pick up the abnormal vessel. You see it? You see us right in the middle of the screen. This giant, that's not even supposed to be here. The big bubble there, that's not even supposed to be here. You see it
Did you
there?
have that for a long time?
You can have that for a while. Yes, absolutely. So this not so that's the brain, that's the aneurysm that ruptured. So we take three-dimensional pictures of it, and look, we can rotate the image to see how we're going to treat it.
When you say for a while, I mean, can this be last for years?
Years. It could be there for years. Now, aneurysms are like balloons. The bigger they are, the more dangerous. So if you think of a party balloon, like really inflated, you want to touch it, it can pop, right? But when it's deflated small, you can touch it, play with it, throw it around, nothing happens. But when they're big, this is when the danger. So aneurysm are the same way.
Do they typically always increase in size over time, or
No,
no, they just get to a certain size and then it's constant?
that's exactly right. So most, 2% of people in the United States have an aneurysm. We know that from autopsy studies, but most of them, 70% are very small, like 2 or 3 millimeters, very, very small. You know what I mean? So, and those are not a problem, but they can grow. But for example, Tom, at your age, if you had, God forbid, if you had an aneurysm, it would never, probably highly unlikely will ever grow. So if it's very, very small, 2 or 3 millimeters, there's nothing to do about it because it's gotten as big as it's going to get. You know what I mean?
I have to tell you, I had an aneurysm 2 years ago, not in my head, but I had an aorta.
Yes, aortic aneurysm is very common.
And I was in the hospital at Christ for 11 days. And I don't know if you know, I had Dr. Hamad Farhat.
He's one of my good friends, work with him all the time. Yeah. He put a stent? Did he put a stent there?
He saved my life. So, and that's the main reason I came tonight, to find out, and I had no idea about it.
No, you can't tell. That's the problem. And that's the biggest problem with the aneurysm. Same thing with brain aneurysm. They have no symptoms. Sometimes very few symptoms. So there's a very rarely they can, but there's no symptoms until they boom, hemorrhage. You could be, this patient was taking a bath. You could be watching TV. You could be just hanging out, and it just ruptures on you without any warning sign. That's the problem. That's the problem.
Yeah, I'm confused here now. You've got blood flow.
But blood stops.
The blood stops.
The
That's what I'm
stops.
gonna ask. What happens?
That's exactly. So you stops because, and it's hard to see here, and I'm going to try to make a point. So this really bright white there, that's the aneurysm. You see around it is like white, but it's not as bright. You see that? That is the blood that came out first. So that sort of tamponades it temporarily. It's not, it can re-erupt. What you asked is an excellent question. When these patients come in, they have 4% chance of rupture within 48 hours. So what we do when they come in, we take them right away to treat. And that's what I'm going to talk about. So they stop temporarily because the pressure on the outside becomes so great that it stops. It's like kind of, if you bleed it, you put pressure. And that's what this does. It puts pressure on it. Stops the flow for temporarily, stops the bleeding here. So it stops temporarily, but it can certainly re-bleed if we don't treat it.
So in this case, we're not really blocking the blood flow, but with a clot.
Yeah,
This just expands on the side, and then the blood can't continue.
that's right. Blood can continue because of the clot and there's pressure on the outside. Now, the blood still flows inside the arteries because it's got somewhere to go. But here, on the outside, like here, it stops. But again, that is a temporary situation because your blood eats away at the clot. Eventually, you can rebleed. You cannot leave that alone. You can't just say, oh, it stopped bleeding. It's not how it works. So you have to treat this aneurysm.
So once again, on the one you're talking about, that aneurysm, that did not burst yet.
It did.
Oh, it did burst.
So that's why the patient came in. The patient came in a coma. She came in a coma and she had bleeding right here. You see the bleeding right there where my pointer is?
All right.
So she had bleeding. And she came in and she had bleeding. And that was the aneurysm. And that was the aneurysm here. And that shows it to you on the angiogram. You see it's pretty big right here. That's before the treatment. So then we treated it. And the way we treated it was coiling, where we actually stuff it, if you will. Here's another picture. That's before. You see it right there? Clearly, because all angiographers now, you see this big black thing here. That's a big bubble. It's not supposed to be there. So we treated it with coils. So we stuffed it like a turkey. And now look at that. It was right here. You don't see it anymore, right?
Right.
You don't see that anymore. Yes.
What size was that aneurysm?
Great question. This was big. I think this is about 12 millimeters. It's big. But you see that? It's stuffed like a turkey. It's not, you don't see it anymore. It's gone. That's it. So this aneurysm will never rupture on you again. It's treated.
So you kind of strangle the bubble.
Yeah, I closed it off. I closed it off from the inside.
So does this aneurysm happen quickly or over time?
Over time. Over
How
time.
much time?
Hard to say. Because we do see some patients that we discover 2 millimeters, we wait for them, they're 4, they're 3, they're 5, but I mean, it's unpredictable. I've done an 11-month-old with an aneurysm that ruptured. That was 11-month-old. Yeah, I've done a 3-month-old, in fact, actually. But these were genetic aneurysms. They're different types of aneurysms. That's because there was something wrong with the blood vessel wall. So it was weak. So that's a genetic problem. But
No,
see,
but the majority of aneurysms, the rate of having an aneurysm increases as you get older.
absolutely, that's correct. That's correct.
Okay. And so for someone who is a senior citizen, what? It is not typically, the only way you find out if you have an aneurysm, is you have to have a CAT scan. Is that correct?
It's a special type of CAT scan. It's a CAT scan that looks at the blood vessels. It's a CTA or MRA. The key word is A. A is artery, arterial. CTA.
Okay.
Well, a regular CT scan will not show it unless it's like this giant, huge aneurysm, like very large, it's obvious.
So once again, what was it? An M?
A CTA, A, like the letter A,
Okay.
or an MRA instead of MRI, MRA.
And I already mentioned, I had an aneurysm. It is, I have been told, I asked about a year later, should I have another? What,
Scan, yeah.
Do I-
But that's for the abdomen. That's a little different, but yes, you can have a CT of the abdomen, yeah.
So what is the medical recommendation for someone elderly who
Sure.
is likely to have an aneurysm or who has had one? The frequency of getting retested over the years. I believe I was told, it's unlikely that you'll get another one.
Yeah, Dr. Sahan is right. It's unlikely if you have it, it's unlikely, especially if you put a stent, which I suspect he put a stent in you. You can do it for the abdomen, it's easy, you can do an ultrasound. And actually it's often recommended as you get older. I'm not sure if any of you guys have had an ultrasound to check specifically for an abdominal aneurysm. That's a classic order that we do, more common, in men, in fact. But yes, we always hold the patient with all the ultrasound of the abdomen for that. But once it's treated and it's gone away, unusual to develop a new one.
So as people get older, do you recommend that they have tests for this?
It's a great question. So there's no FDA recommendation for the brain unless you have 2 first-degree relatives with brain aneurysms. Then, in fact, the insurance company will cover it because there's about 15% chance of you having it, between 15 and 20% chance of having it. So if you have like a mom and a sister, 2 sisters, a father and an uncle, things like that, then you should definitely do it. And everyone else too, like your kids, that should test it.
How often?
Just at least one time, just to see if you have it or not, And if you don't, you can get it, 10 years later, things of that nature. Those develop very slowly over time. If you don't have anything, the chance of developing it when you're older is low. Like if you're older than 50 or 60 and you have no aneurysm at age 50 or 60, the chance to develop in the next 10, 20 years is low.
But you don't know, it could still happen.
It can still happen. You're right. You can always get an MRA, which is not, you know what I mean? Yes, ma'am.
Where do you enter to clear the brain aneurysm? What part?
Good. We enter through an artery. It's called the femoral artery. It's right here. We can enter, there's 2 ways. We can enter an artery right here, either here or here, or a radial artery here or here.
The brain?
Yeah, and we go over. Yeah, no, this is that's what he was asking earlier. He said all these wiggly and turns, and that's exactly right.
What makes a difference when you go into the groin or the wrist?
It's a great question. So this artery is a lot smaller. So if we think we need bigger size catheters and things of nature, we go through groin. Now more and more, the technology is evolving where the companies actually making better catheters to go through here and access. And some people have problems in the groin here. That's a very common area to have issues. Some people have stents down here, they have bypasses, things like that. So we got to skip that and go through here. So it's a lot of things. That's a great question. Yeah. So this aneurysm was treated. I mean, we can go look at that. You can't even see it anymore. It's all gone. Gone. So look at it. You can't even see it anymore. So that's the same patient, all gone. This is another patient with a very large aneurysm. You guys see the aneurysm right there, right? That's huge. That's right. It's huge. So we treat, look at it. It's huge. I mean, these arteries look so small compared to this giant bubble. Here it is. That's before on the left and after, completely gone. Look at how many, that's what it looks like on the x-ray. Patient did great. And that was discovered before it ruptured. This is a patient that was unruptured. We put a special coils and stent. Again, all gone. But I'll leave it at that because I think it's getting late. But that's the point of this. But I encourage you guys to not be afraid of going to the hospital, not be afraid of getting these procedures done if you need them. Because some of these aneurysms could be discovered when they're not ruptured. The technology has evolved. We're way better now. Some of these aneurysms are done in 15 minutes. People don't even my patients go to the floor. They don't go to ICU and they go home the next day, the next morning. They could go home the same day, but I'm safe. I keep them one day. So the technology got better. We've gotten better. And don't ever be afraid of calling, Tom. I hate the fact that the insurance company charges you stuff like that. Believe me, I'm the kind of, I don't even know how it works, to be honest. But it's rather be safe than sorry, right? That's what they say. But then if you have a TIA, you gotta come.
Now, what do we do now to alleviate these problems?
Great question. I mean, listen, there's no pill, you know what I mean? No, but you gotta be healthy. You gotta avoid high blood pressure. The number one risk of stroke, high blood pressure. The biggest issue we have high blood pressure, and it's very common in African-American community. And I think you're aware of that, right? The problem with blood pressure is that when you lower your blood pressure, sometimes you don't feel as good. So a lot of patients don't like to take the medications because you feel you're not as, you feel a little more tired, maybe not as, you know what I mean, as energetic, things of that nature. So it becomes a conundrum where it's important, you know what I mean, but it doesn't always make you feel good. Get used to it. So blood pressure, number one. Smoking. It's a risk factor. It's a risk factor for having aneurysms, brain aneurysm actually. It makes your blood vessel weak. That's the same thing with the heart. Alcohol is not, listen, I'm not gonna, it hasn't really been shown to have any issues, but it does have some toxic effect on the heart if you, a lot. Now, and I'm talking about somebody excessive, like 2 bottles a day. That's really bad. If you have 2 drinks a day, one or 2 drinks, that's not that bad. Okay. Other things, just being healthy, cholesterol. Check your cholesterol, and basically see a doctor for preventative care. Tom here had the abdominal aortic aneurysm treated before anything devastating happened because that could rupture, and you have a problem. Now, it's not going to rupture on you.
Oh, I should mention, I had blood in my urine. I went to my urologist and said, I kind of complained, what's the problem? He said, you have to go and get I thought it was a CAT scan. And I got to the imaging service that did the CAT scan. And by the time I got home, they told me I have to go immediately to the emergency room because they found a very large, they said it was an 8 centimeter
abdominal aortic aneurysm.
Aneurysm, yes.
AAA, they call it AAA.
And I couldn't believe it. I had no idea. And when I got to the hospital, they said, based upon your heart stress test, we believe you had a heart attack. because the value of your heart efficiency is only 35%,
Yeah,
and the normal heart efficiency is 55%.
isn't it crazy?
I said, that's news to me. I had
Yeah.
no idea I had a heart attack.
Yeah,
But then I was told later that there is no causal relationship between the aneurysm and a heart attack.
that is true, that is true, and but I'll tell you something, Tom. You know what they say? God works in mysterious ways, doesn't he? You get a little blood, you get a little blood in the urine. Next thing you know, you get in that aneurysm treated. So, you know, somebody, he's looking after all of us. He or she are looking after us. Isn't that amazing?
Alive by the grace of God.
Isn't that amazing?
Which is the reason I'm in the front row of your lecture, to make sure nothing further happens.
I hope everything makes sense. I'll try to make it as simple, and I hope it was fun. Some of the cases, I mean, I really, think, our patients are, it's a privilege for me to work with patients like this that trust me and my team, and I have a wonderful team. So really a privilege, and the entire medical community have learned so much from patients in general over time. And we really owe a lot of, and some of them, unfortunately, obviously, had issues and problems and didn't all make it. But they make all of us better, all of us better. So we all appreciate it too.
See the passion he exhibits, right? Do you think he likes what he does?
Absolutely.
So. And he's great at it. So thank you very much, Dr. Hamad. I really appreciate it. So before you all leave, I'm gonna make sure you all know the answers. All right. Yeah.